Hi, hello, and welcome to my channel Easycology with Bud. So, today we will be discussing about pharmacology of oral hypoglycemic drugs. So, what is diabetes mellitus? Diabetes mellitus is a condition, it is a metabolic disorder which is characterized by hyperglycemia, which means elevated blood sugar, and it is caused either due to the relative or absolute deficiency of insulin. So, if you see the classification of diabetes mellitus, predominantly it is divided into two types. One is insulin dependent, other one is non-insulin dependent. So depending on the patient population, it predominantly affects. It is also called as juvenile onset diabetes mellitus or maturity onset diabetes mellitus. So let us see what is insulin dependent diabetes mellitus. So as the name suggests, it is going to be dependent on the insulin. So in this type of diabetes mellitus, the circulating levels of insulin is going to be low or very low. So this is because either due to an autoimmune response or a chemical toxin or a virus, the beta cell is going to be destroyed. Now what is beta cell? Beta cell is a cell in the pancreas islet of Langerhans which is responsible for the secretion of insulin. So now when the cell that secretes insulin is destructed, then automatically insulin is going to be low or very low. So that is called as insulin dependent diabetes mellitus. The second type is non-insulin dependent diabetes mellitus, where insulin is produced by the body, but the way the body is responding to the insulin is having some problem. For example, insulin will be secreted only in response to glucose, that we know, right? So the insulin is going to detect the presence of glucose around it, and that's how it will be released. Now if there is any problem in the detection mechanism or the sensing mechanism, that is the glucoreceptor which is going to sense the glucose outside and help in the release of insulin. If that is having any problem, then that is going to cause non-insulin dependent diabetes mellitus. The second type is, now insulin is going to be released. So once insulin will be released, generally it will be taken and it will be disposed into the skeletal muscle or the adipose tissue. Okay, so those are called the peripheral tissues, right? So when the peripheral tissues is having decreased sensitivity to insulin, then it is also going to cause non-insulin dependent type 2 diabetes. Okay, so type 2 diabetes or non-insulin dependent diabetes mellitus. So you have to remember this is also called as insulin resistance, where insulin is produced but the way the body is responding is going to be different. Okay, either it is going to be reduced sensitivity of the peripheral tissues to insulin, or there should be an abnormality in the glucoreceptor of the beta cell, so they are not responding to the glucose concentration. So these are the two types of diabetes mellitus. Now let us see the classification. First classification is insulin secretagogues, which means they are going to enhance the production of the insulin from the beta cell. So you have to remember, for this type of drug, the pancreas islet of Langerhans should be at least partially functioning. That is how it will release insulin, right? If it's not functioning, then insulin will not be released. So insulin secretagogues will increase the insulin secretion from the beta cell. We have two types of drugs under this, two categories. One is sulfonylureas. First generation is tolbutamide. Second generation is glibenclamide, glipizide, gliclazide and glimepiride. So all the second generation drugs is going to start with G. So you have to remember like that. Second is meglitinide, and the drugs are repaglinide and natglinide. Okay, so you have to remember sulfonylureas and meglitinides. Second is insulin sensitizers. So I told you what is insulin sensitization, right? So these type of drugs is going to help us overcome the insulin resistance that is seen in type 2 diabetes mellitus. Okay, so there are two types of two categories of drugs that comes under this. One is biguanides, that is metformin, and thiazolidine diones. Thiazolidine diones is also called as glitazones. So pioglitazone, rosiglitazone will come under this category. Third one is the glucagon-like peptide agonists, GLP-1 receptor agonists, also called as incretin mimetics. So here we have drugs like exenatide and liraglutide. And the fourth category is DPP-4 inhibitors, that is dipeptidyl peptidase 4 inhibitors. So we have a category of drugs here called the gliptins, sitagliptin, linagliptin, vildagliptin, saxagliptin. So all the gliptins will come under the fourth category. And next is the Miscellaneous drugs. So in miscellaneous drugs we have alpha glucosidase inhibitors, and we also have sodium glucose co-transporter inhibitors. So alpha glucosidase inhibitors, the examples are acarbose, voglibose, and sodium glucose co-transporter inhibitors are the gliflozins, that is the dapagliflozin. So now we'll go to the pharmacology of the oral hypoglycemic drugs. So before you understand this, you have to understand the mechanism by which the insulin is going to be generally released. So for example, now if this is the beta cell, this beta cell is going to sense that the glucose is outside the cell, like the glucose is increased. For example, this is glucose and this is the beta cell. So the glucose will come inside the beta cell with the help of a transporter called the GLUT transporter. So once it is going to come inside, it will be metabolized by an enzyme called as glucokinase. So once it is metabolized by glucose kinase, it is going to activate the glucose sensors. Okay, so once glucose sensors is going to be activated, there will be one channel in the beta cell which is the potassium sensitive ATP channel. So once glucose sensors are activated, this potassium sensitive ATP channel will be inhibited. It will be blocked. So once this is blocked, then what happens? The calcium channel which is present on the beta cell will be opened. So there will be an influx of calcium. So once there is an influx of calcium, there is going to be a vesicle which is having insulin in it in the beta cell, right? So once the calcium is going to be released, this vesicle having the calcium is going to be broken and the insulin will be released. So this is the mechanism. Okay, so what happens? The glucose, the insulin is going to detect the glucose outside, and the glucose is going to come inside with the help of the GLUT co-transporter, where it is going to be broken down by glucokinase. It activates a glucose sensor which is going to inhibit the potassium sensitive ATP channel, because of which there is depolarization. Depolarization causes the opening of the calcium channel and the exocytosis of the insulin vesicle, and because of which the insulin is going to be released. Okay, so that potassium sensitive ATP channel, you have to understand the significance of potassium sensitive ATP channel. So the first category of drug is secretagogues, which I told you is going to promote the insulin from the beta cells of the pancreas. And the two categories of drugs that are secretagogues are sulfonylureas and meglitinides. So the target of sulfonylurea is one receptor called the SUR1 receptor. Okay, SUR1 receptor, which is present in the ATP sensitive potassium channel, which I was talking before. So in the ATP sensitive potassium channel, there is one receptor called the SUR1 receptor. So sulfonylurea will bind to this SUR1 receptor, and then it will inhibit this channel, because of which there is depolarization. And because of which the calcium channel opens, the calcium will undergo influx, and then the insulin will be released. Apart from that, it is also helpful in the reducing the hepatic glucose production and also increasing the glucose sensitivity. So this is the mechanism of action of sulfonylureas. If you see the adverse effects of sulfonylurea, it is going to cause weight gain. Okay, weight gain is an important side effect or adverse effect of sulfonylurea. And second one is the hypoglycemia. Okay, so because this category of drug is going to directly release insulin from the beta cell, right? So weight gain is caused because of the hyperinsulinemic action. Insulin itself has an action of where it is going to take and mobilize and dispose the glucose into the adipose tissue and all, right? So because of the hyperinsulinic reaction itself, it is going to cause weight gain, and because of the direct release of insulin, it can cause hypoglycemia, where decreased blood sugar levels are seen, and also it is responsible for hypersensitivity. Okay, next is meglitinide. So it is also going to bind to the same target as that of sulfonylurea, that is, it binds to a distinct site in the SUR1 receptor, because of which it has same mechanism of action as that of sulfonylurea. But one difference is that it is going to bind very loosely to the SUR1 receptor, so it has short duration of action but rapid onset. So since it has rapid onset, it is effective against postprandial glucose. Okay. So the adverse effect is also very similar to that of sulfonylurea, but since it is loosely bound, it is having less incidence of the adverse effects. So you have to always remember sulfonylurea, the major adverse effect is weight gain and hypoglycemia because of the hyperinsulinemic action. The next category of drug is insulin sensitizer, which is not going to increase the insulin released from the beta cell, but instead it is going to improve the target cell response, that is the sensitizing action. So here there are two categories of drugs. One is biguanides and the other one is the thiazolidinediones. So biguanides we have metformin, thiazolidinediones we have the glitazones. Okay, so metformin is the most commonly used drug, and if you see its target, it is going to be a activator of AMP dependent protein kinase. Okay, so AMP dependent protein kinase. So what is its major action? If you see, it is going to suppress the hepatic gluconeogenesis and glucose output from liver. So as I have already told you, it's an insulin sensitizer, right? So it is going to improve all the sensitizing action. What it will do, the insulin mediated glucose uptake and disposal in skeletal muscle and fat, it is going to promote that. And by interfering with the mitochondrial respiratory chain, it is going to promote peripheral glucose utilization. It will suppress the formation of new glucose, that is gluconeogenesis, and also glucose output from the liver. So all the sensitizing actions, that is taking the glucose, putting it in the fat and skeletal muscle, and also promoting the peripheral glucose utilization, everything is the function of biguanides. So apart from that, it is also having one function, that is it will retard the intestinal absorption of glucose and other hexoses. Okay, so this is the mechanism of action. You have to remember the target is the AMP dependent protein kinase activator. So what is the adverse effects? It has GI effects, lactic acidosis and vitamin B12 deficiency. So how you can remember is that there is one point here. It retards intestinal absorption of glucose and other hexoses. So you can correlate this point to the GI effects. So maybe since it is going to retard the absorption, so maybe there might be some GI effects like loose stools, diarrhea and all. Lactic acidosis also you can correlate, to remember I'm saying. Okay, so GI effects, lactic acidosis, there is a small increase in the lactate concentrations in the blood, but it is very rare. But still you have to remember lactic acidosis. Vitamin B12 deficiency is because it is going to retard the absorption of vitamin B12, so there is a deficiency. So these are the three major adverse effects: GI effects, lactic acidosis and vitamin B12 deficiency. But you have to remember biguanides will not cause weight gain. Okay, so instead it is a weight loss promoting drug, and it is also not going to cause hypoglycemia. Okay, it will not cause hypoglycemia. So it is very different from sulfonylurea and meglitinides because it does not cause weight gain, it does not cause hypoglycemia. And next we have thiazolidinediones. Thiazolidinediones is going to activate a nuclear receptor, that is PPAR gamma. This PPAR gamma is going to be present in the adipocytes, that is in the fat cells. So you have to remember the mechanism of action is predominantly going to revolve around the fatty acids. Okay, so since it is a nuclear receptor, once nuclear receptor is activated, it is going to start the transcription of insulin responsive genes. That is the first one. So since it's a nuclear receptor, you have to talk about transcription, right? So it is going to cause the transcription of insulin responsive gene. Second, it is going to reverse the insulin resistance by enhancing the GLUT4. So what is the insulin resistance? What did I tell you? That either the glucoreceptor is going to be abnormal, or second is there is reduced sensitization response with response to the insulin, right? So what they're going to do, they're going to enhance the glucoreceptors, that the transporters GLUT4. So when the transporters are going to be increased, the the insulin resistance will be reversed. So that is the second point. And third point is it is going to cause the entry of the glucose into the liver and the muscle. It will also cause the fatty acid metabolism and lipogenesis in adipose tissue. So you have to remember thiazolidinediones is going to act on PPAR, which is present in adipocytes. So this is going to cause the metabolism of fatty acid and lipogenesis in the adipose tissue, and it is going to increase the adipocyte turnover and differentiation. So why is all this happening is because in order to prevent the fatty acid from being the major source of energy. Okay, so if fatty acid is going to be used as an energy, then glucose will be building up, right? So that's why we are going to promote the lipogenesis in the adipose tissue and fatty acid in the adipose tissue, so that the fatty acid will not be used as a major source of energy, and also adipocyte turnover and differentiation will be increased. You can also see it is going to lower the triglyceride formation and raise the HDL, but it will have no effect in the LDL. So the adverse effect here is weight gain. Again, you can correlate and you can remember that since it is going to act on the fatty tissue, now the adverse effect has to be weight gain. So you can remember it like that. So we have studied two things. One is biguanide, which is AMPK activator. The other one is thiazolidinedione, which is PPAR gamma agonist. Okay, so biguanide, you have to write all the points that is going to be related with sensitizer, like it is going to put the glucose in the skeletal muscle and the fat, and it will promote the peripheral glucose utilization. So all these points you have to remember, and also with the intestinal absorption retardation, you can remember the adverse effects, GI effects, lactic acidosis and vitamin B12 deficiency. Okay, and thiazolidinediones, you have to talk about transcription, and again majorly about the fatty acids you have to talk. Okay, so this is the second category. The third category is GLP receptor agonists or incretin mimetics. Okay, so what are incretins? You have to know. Incretins are substances that are going to be released in response to the ingested glucose. Okay, so what is the function of the incretin? Whenever you're going to take glucose, incretin will be released, and the function of the incretin is it is going to induce the insulin release from the beta cells. It is going to slow the gastric emptying. It will suppress the appetite by activating the GLP-1 receptors. Okay, so these are its functions. It is going to increase insulin, and all these functions it is going to do. So if we are going to have a substance which is mimicking incretin, then it is going to be of advantage to us. So that is the function of liraglutide and exenatide. It is going to mimic the incretin that can stimulate the insulin from the beta cell, promote gastric emptying and suppress the appetite. Okay, so this class of drug does not have very serious adverse effects. So it is going to have the adverse effects which is the favorite of every pharmacology student, which is nausea, vomiting and diarrhea. So it is easy to remember. Next category is DPP4 inhibitor. So DPP4 enzyme, you have to know what is it. What is DPP4 enzyme? It is an enzyme that inhibits or degrades incretins. Okay, so if DPP4 enzyme degrades incretin, then the function of the incretin, like the release of insulin, slowing down gastric emptying, suppressing appetite, will be decreased. So you have to inhibit this DPP4 enzyme so that the function of the incretin is retained. So that is the function of DPP4 inhibitors, like all the gliptins, saxagliptin, linagliptin, sitagliptin and all. So what are its adverse effects? Since it is going to be interfering with the degradation of the substance P. Okay, so it is going to cause adverse effects such as nasopharyngitis and cough. Okay, so you can remember this. So recently in COVID infections, DPP4 was considered as an important receptor and enzyme, right? So you can remember that DPP4 is related to infection. So nasopharyngitis and cough can be one of the adverse effect. Okay, so you can remember it like that, but this side effect is not because of that. It is because of substance P degradation, but still you can remember it. You can relate it with infection and remember these points. So another one point to remember here is GLP receptor 1 agonists is also a GPCR. So it is going to trigger the GS type of receptor, and then it will activate adenyl cyclase and it will convert ATP to cyclic AMP, and cyclic AMP will promote calcium and then cause the insulin release. So that is how it is going to release the insulin, because it is a GS type of GPCR. So this also you have to remember. And the final category of drug is A-carbose inhibitors and sodium glucose cotransporter inhibitors. So A-carbose inhibitors, what is A-carbose now? It is not A-carbose inhibitors, it is alpha glucosidase inhibitors. Okay, the drug is A-carbose. So alpha glucosidase is an enzyme which is going to convert complex polysaccharides into simple sugars like glucose. That is the function of the alpha glucosidase. Okay, so now we do not want glucose here, right? So we have to inhibit this alpha glucosidase. So we are going to use an inhibitor of alpha glucosidase like A-carbose, voglibose. That is its simple function. But what happens now, because we are going to inhibit the conversion of polysaccharide to glucose, it will be in the intestine, and slowly it will start fermenting, right? So because of that, some abnormal adverse effects are going to be starting, like flatulence, abnormal discomfort, loose stool. All the GI complications will start because of the fermentation of that polysaccharide. Okay, so apart from that, it is also going to release GLP-1, which is incretin, and postprandial glucose is also decreased. So same point we also saw in meglitinides, right? Postprandial glucose is decreased. So this alpha glucosidase inhibitor is a complex oligosaccharide itself, and it is going to inhibit the alpha glucosidase enzyme, which is present in the brush border of the intestine. So next is the sodium glucose co-transporter inhibitors. So generally what happens whenever we are going to take glucose from the glomerulus, it will be filtered, and then it will go to the proximal convoluted tubule, from where it will go to the blood by the help of SGLT2 transporter. So now we do not want the glucose to be in circulation, right? So we are going to inhibit this enzyme, this transporter. So once this transporter is going to be inhibited, then instead of going to the blood, it will be excreted through urine. So it will promote glycosuria. But now there is going to be increased amount of glucose that is going to be excreted through urine, right? So when your sugar is there in the particular urinary region, then what happens? Too much sugar, there will be infection. So that is the adverse effect. Urinal and genital infection will be there, and also increased urinary frequency and electrolyte imbalance. Okay, so this is the adverse effect of sodium glucose co-transporter. So in case if you want a pictorial representation that will be easy for you to refer before exam, I am also preparing a short video which is shorts. Okay, so you can refer that in a glance, you can prepare for your exam. Thank you. You can also test yourself by the questions that I have posted here. If you know the answers to these questions, then please do comment below. So the first question is, which of the following is a oral oligosaccharide hypoglycemic agent administered at the start of the meal? Okay, at the start of the meal, which is a oligosaccharide hypoglycemic agent? So I have told it in the between the video. So if you remember, just comment below. Which agent acts as hypoglycemic? As ATP sensitive potassium channel blocker. So comment the answer below. Which enzyme degrades incretin? So if you know the answers, you comment below. And if you want the pictorial representation of this entire chapter, you can, I am also putting the link in the description below for the shorts video. You can refer to that. Thank you.